In this video, we'll look at the different types of nosebleeds, which ones to worry about, and the principles of managing them. A nosebleed, or epistaxis, happens when a fragile blood vessel in the nose breaks. This is more likely to happen when the lining of the nose, the mucosa, becomes drier and thinner, causing the vessels within it to become more vulnerable to things like trauma. Most of us will have experienced nosebleeds and not needed to see a doctor because they resolve spontaneously. These normal nosebleeds are particularly common in children, who are generally more likely to pick their nose, and the elderly, who are generally more likely to have vascular risk factors. Abnormal nosebleeds might still self-resolve, but occur very frequently, in which case the patient should see the GP to look for an underlying cause. The more concerning nosebleeds that should be seen in A&E and may require ENT interventions are ones that are prolonged, meaning they persist despite 10 to 15 minutes of compressing the nose, or the ones that are severe enough to make the patient unstable. Bleeding from both nostrils is another concerning sign that suggests that the blood is coming from a more dangerous location, as we'll see later on. The first step to understanding nosebleeds is knowing where the blood might be coming from. The nose receives a dual blood supply from branches of the internal carotid artery and the external carotid artery. The internal carotid artery branches into the anterior and posterior ethmoidal arteries within the nose, whereas the sphenopalatine, greater palatine, and superior labial arteries originally come from the external carotid artery. Most of these arteries come together and anastomose in the anterior part of the nose to form a network known as Kieselbach's plexus. And this plexus is found in a part of the septum called Little's area. And this is clinically important because it's the most common origin of anterior nosebleeds. And actually about 90% of all nosebleeds come from this area as well. For the sake of exams, you can remember that sticking a little finger up your nose can damage Little's area. The other vascular region to be aware of is Woodruff's venous plexus, which is thought to be the cause of most posterior nosebleeds. Now, it's not always possible to localize the exact vessel responsible for the nosebleed, but identifying roughly where the blood is coming from, whether it's anterior or posterior, is really important because it determines your management approach and helps identify risk. As we already saw, anterior nosebleeds usually arise from Kieselbach's plexus, and they make up the vast majority of cases. They should just involve one nostril, and the blood tends to flow forwards, out of the nostril, which then makes it easier to manage. Posterior epistaxis, on the other hand, should be suspected if blood is coming out of both nostrils, and these nosebleeds are more concerning. This is because, firstly, the anatomy means that they are harder to visualize and localize, and secondly, the blood is more prone to flowing backwards into the pharynx and the trachea, which then leads to a high risk of aspiration. Now let's look at the main causes of nosebleeds. And as we saw earlier, the root cause of a nosebleed is a fragile vessel breaking, which is more likely to happen when the nasal mucosa is dry and thin. So the factors which predispose to nosebleeds will either cause the vessels to be more fragile, directly damage the vessels, or dry out the nasal mucosa to make the vessels more vulnerable. Examples of direct trauma to the vessels can be as trivial as nose picking, or more significant blunt traumas to the skull. Some people experience nosebleeds on a seasonal basis, and it's specifically the dry weather that's an issue, because it dries out the nasal mucosa. So when people get nosebleeds in the winter, it's usually because putting on the central heating dries out the air in their home. Disturbances to the clotting cascade can cause prolonged nosebleeds, even from trivial trauma, and these disturbances range from taking anticoagulants to having an inherited coagulopathy. Snorting cocaine over time causes damage to the septum, where the main vessels involved in nosebleeds are found. However, even medications such as intranasal decongestants and steroids can cause nosebleeds if they're incorrectly applied to the septum or used for extended periods. And finally, having an anatomical abnormality, like a deviated septum, will affect the airflow through the nose, and exacerbate the drying effect that inspired air has on the nasal mucosa. Those were the most common causes of nosebleeds, but there are a few sinister causes that should be ruled out, particularly when the nosebleeds are severe or recurrent. Hereditary hemorrhagic telangiectasia, or HHT, is a genetic condition that causes malformed, fragile blood vessels to develop in various parts of the body. The most common place to find these abnormal vessels is the nose, which is why over 90% of patients with HHT have nosebleeds, and often very bad and prolonged nosebleeds. These patients classically have other visible lesions on the tongue and on the skin surrounding the lips and fingers. A malignancy called nasopharyngeal carcinoma should be ruled out as well. This may also cause associated hearing, breathing, and speaking difficulties. In younger patients, a vascular tumour called juvenile nasal angiofibroma may be responsible, and although these are benign, they are locally aggressive. And finally, a rare but important systemic cause is granulomatosis with polyangiitis, which produces inflammation of the blood vessels and almost always affects the upper respiratory tract. Nosebleeds can be investigated using a bedside bloods and imaging approach. By the bedside, we can examine the nose, looking at the external surface for any obvious deformities, tumours, or vascular lesions. To look inside the nose, we can use a nasal speculum and perform anterior rhinoscopy. This then allows us to start searching for any foreign bodies and the problematic blood vessel itself. If the bleeding is particularly severe, you might need to check the hemoglobin and prepare for a potential transfusion. And then further blood tests, like an autoimmune screen, can be considered to investigate the underlying cause, although they won't be performed in the acute setting. Imaging isn't normally necessary unless the cause is a suspected facial fracture, in which case a CT of the facial bones would be needed. And a more invasive camera test to look inside the nose, called endoscopy, might also be performed to look for the source of the bleeding if it isn't found during anterior rhinoscopy. Now let's look at how we can manage nosebleeds. In the acute setting, the first step is to take an A to E approach. And with severe bleeding, the main things are ensuring that the airway isn't compromised by the blood and that the patient is hemodynamically stable. We can then take basic first aid steps, sit up and tilt the head forwards to prevent aspiration, and apply pressure to the soft cartilaginous part of the nose for 10 to 15 minutes. You can consider applying ice packs to the nasal bridge to cause vasoconstriction, although it isn't always done. The next part of management depends on whether it's an anterior or posterior nosebleed, which is why it's important to distinguish between the two. For anterior bleeds, there's a better chance of localizing the source, so to begin with, we can try to cauterize it. If this fails, the second line management is anterior nasal packing, and then there are some surgical interventions that might be needed as a last resort. There are two types of cautery, chemical and electrical. Chemical cautery involves alternating between applying cotton wool balls soaked in local anesthetic and silver nitrate cautery sticks to the affected area. Electrical cautery can be used instead where the blood vessel is sealed using diathermy. Anterior packing may initially be attempted using dissolvable products such as foams and gels that promote clotting, because they don't need to be removed later on and carry a lower risk of infection. If this fails, there are a range of non-dissolvable products that can be used, such as nasal tampons and inflatable balloons. The pack should be reviewed with an aim to remove after 24 to 48 hours to reduce the risk of infection and potentially even toxic shock syndrome. Prophylactic antibiotics are often used as well for the same reasons. The algorithm is different for posterior bleeds because the source of bleeding is likely to be harder to visualize and cauterize. Therefore, the first line option is posterior packing, and again, there are surgical options if necessary. Posterior packing is a bit different. It involves threading a Foley catheter through the nasal cavity, inflating the balloon, and positioning it to occlude the choani, which are the openings that separate the nasal cavity from the nasopharynx. And an anterior pack should actually be inserted alongside this. If all of these options fail, then surgery is required. One option is endoscopic ligation, where an endoscope is inserted into the nose and a major artery is sealed off. Alternatively, an interventional radiologist can perform angiographic embolisation, where a tube is inserted into an artery in the groin and eventually guided towards the problematic blood vessel in the nose under X-ray guidance. The radiologist then inserts some small particles via the tube to seal off the vessels from the inside. And both of these interventions will typically target the sphenopalatine artery. Once the nosebleed has been acutely managed, you can then give a course of Naseptin, which is a cream containing an antibiotic and a disinfectant that helps to reduce crusting and infection. You also need to manage the cause of the nosebleeds, for example, treating risk factors like hypertension, or maybe even investigating for rare underlying diseases.